persons for this session. And special thanks to Dr. Avneet Kaur for providing me this opportunity. Now, the topic of my presentation is RH blood group system and D variants. This is a very vast topic, and I hope I'll be able to do justice to this topic within the time frame allotted to me. So, my presentation will be under these following broad headings: history, terminology, genetics, antigens and variants, antibodies, RH typing and clinical considerations, and the RH resources. The RH system is second in importance to the AB blood group system, and the D antigen is highly immunogenic. It is implicated in hemolytic disease of fetus and newborn and hemolytic transfusion reaction, and the ISPT number is 004, whereas the chromosome number is the short arm of chromosome 1. If we look at the historical timeline, dates back to 1939, when Levine and Stetson they discovered hemolytic transfusion reaction in a woman after delivery of a stillborn child following transfusion of her husband's blood. The fetus and father had a factor which was lacking in the mother. However, no name was proposed at this stage. In 1940, Landsteiner and Weiner they injected the rhesus monkey. They observed that the rabbit serum agglutinated rhesus monkey red cells and also 85% of the human red cells. And now these these individuals were named as Rh positive, whose red cells were agglutinated by this rabbit serum, and the rest were labeled as Rh negative. Whereas in 1941, Levine and co-workers, they stated that the human antibody which they had identified had the same pattern of reactivity as the rabbit anti-Rh antibody. However, in the subsequent year, authors demonstrated that there was a difference between the animal and human anti-Rh. Subsequently, after 2 decades, it took another 2 decades to see that there was the original term, which was RH, proposed by Landsteiner and Wiener, was retained, whereas the anti-rhesus found by the animals was renamed as anti-LW. Now, in 2020, just a minute, if I can. In 2020, that is the current status, we can see that nearly 60 antigens and more than 600 RH variants have been discovered, and still we are counting. So within a short span of few decades, we have reached to more than 600 RH variants, which is a big dilemma for the blood transfusion specialist. Now coming to a brief about the terminology of the RH blood group system. This terminology is derived from 4 sets of investigators. 2 terminologies are based on the genetic mechanism, and these were proposed by Fisher and Rees, and another was proposed by Wiener. The third terminology is based on the presence or absence of a given antigen, which was proposed by Rosenfield. And fourth is definitely a result of the efforts of the International Society of Blood Transfusion Working Party on terminology for red cell surface antigens. According to the Fisher and Rees terminology, they stated that the RH inheritance is controlled by 3 genes. Each locus has its own set of alleles. So if we look at this diagram, we can see that there are 3 genes: D gene, C gene, responsible for the C uppercase or lowercase c antigen, and the E gene. And this terminology was preferred for written communication. Whereas Wiener proposed a single gene theory, wherein a single Rh gene produced an agglutinogen that contained 3 blood factors, and each factor was an antigen recognized by a particular antibody. This terminology was preferred for verbal communication. What we observe and follow in routine practice is the modified Wiener terminology, in which the Rh positive, the capital R, denotes the presence of D antigen, 1 denotes the C in uppercase, 2 denotes the E in uppercase, and these 2, when present along with Rh positive, are denoted as subscripts. Whereas in case of Rh negative, they are present as a single prime or double prime, and they are denoted as superscripts. And same way, if there is a 0, it means that C and E are in lowercase, and if it is a Z, then C and E are in uppercase in case of Rh positive, whereas if it is a Y, then it suggests that C and E are in uppercase in case of Rh negative. I think most of us are familiar with this terminology. According to Rosenfield alphanumeric terminology, Rh antigens are designated by the number in order of their discovery. So D was the first to be discovered, hence it was given number 1, followed by C, capital E, small c, and small e. And so if one of the antigens is missing on phenotyping, then it is written as minus sign, followed by the other antigens are separated by commas. This type of terminology was well suited to electronic data processing. So if we look at a comparison of the three nomenclatures, we the three which we are all familiar with these. While the Wiener is better for the verbal communication, the Fisher race is better for the written communication, and Rosenfield is better for the electronic data processing. But because of multiple terminologies, it was difficult. So the ISPT, the International Society for Blood Transfusion, in an attempt to standardize the nomenclature, assigned six-digit numbers to each blood group specificity. The first three represent a system and the other three represent the antigenic specificity. So if it is a D antigen, it is written as RH1 and it is 004001. And if you can see in this table, you can see that till date, nearly 61 antigens have already been numbered. Out of this, few have become obsolete, which have been highlighted. These are the RH13 through 16, 24, and 25. But still, we have a lot more of these antigens which are there and which are posing day-to-day challenges in routine serology lab, so which we'll be discussing later on. Now, coming to a brief about the genetics of the RH blood group system. The RH locus is present on the short arm of chromosome 1. An expression of RH proteins is controlled by two closely linked genes which are oriented in a tail-to-tail or inverse arrangement. The RHD gene codes for the presence or absence of the D protein, and the CE codes for the C and E proteins in all possible orientation of the RHD and RHCE genes, which we'll be seeing in the next slide. So this model, which was proposed by Tippett, is now accepted. That is the two-gene theory, two genes located on the short arm of chromosome 1. If we look at this diagram, this is the RHD gene and the RHCE gene. Both of these genes have 10 exons each, and this is the inverse orientation from the 5' terminal to the 3' terminal in case of RHD, and from 3' to 5', this is the RHCE gene. And in between, there is a blood group irrelevant gene, that is the SMP1 gene, which spans about 30,000 base pairs. And this RHD gene is flanked by the two RH boxes. These are the RH boxes which are present in D negative individuals. When the RHD gene is deleted in D negative individual, as we can see in the lower part, these hybrid rhesus boxes remain, followed by the RHCE gene, which is normal in case of D negative individuals. So this is the main topology of the RHD gene, which is present on short arm of chromosome 1. So as we have seen that both genes have 10 exons each, and what is important to notice, there is 97% sequence identity in the coding region of these two genes. And it is believed that RHCE was the ancestral gene, and RHD likely arose from a duplication event of RHCE. And because of this inverted orientation, there is more chances of nucleotide changes. There is facilitation of nucleotide changes due to hairpin loop formation, and this leads to genetic exchange and formation of multiple variants, which we'll be discussing subsequently. Another gene which is important for the RH blood group system is the RHAG, which is located on the chromosome 6. It produces RH-associated glycoprotein. This is very similar in structure to the RH proteins, but the only difference is that it is glycosylated. It is nearly 40% similar to the RH proteins. And its main function is that it is required for the efficient transport of RH polypeptides to the red cell membrane. The mutation in RHAG causes loss of expression of the RH antigens, leading to the RH null phenotype, because without RHAG, neither the CE or D antigens reach the red cell membrane. Hence, it is termed as a co-expressor. However, by itself, it does not express any RH antigens. The inheritance of RH is just like most of the other blood group systems. They are inherited as co-dominant alleles, and an individual can inherit either one or two RHD genes, and two RHCE genes are inherited, one from each parent. So RH positive individuals may express the D antigen in the homozygous or heterozygous form, and the negative phenotypes lack the detectable D antigen. Now, there are three mechanisms by which a person can be D negative. These are the three common mechanisms. In Caucasians, in majority of the cases, the D negative almost always results from a deletion of the RHD gene, as we'll be seeing in the next slide, that how the deletion occurs. So because of this deletion, the D negative phenotype occurs in Caucasians. Whereas in Africans, in 66% of cases, there is a RHD pseudogene. This pseudogene is because of a 37 base pair internal duplication in the 4th exon, which leads to a premature stop codon and an inactive gene. And 16% of Africans may also have hybrid genes leading to D variants, which are very common in African population. In Asians, besides the conventional deletion, a mutation which alters the RHD gene leading to the del phenotype, which is not detected by routine serology, and this phenotype is common in the Asians. So if we see in this diagram, we can see that the RH, this is the RH positive, D positive, where the RHD and CE genes are normal, and these are the 10 exons of both genes. In case of RHD deletion, there are hybrid rhesus boxes are present, whereas the D gene is absent over here. This is the one which is seen most commonly in the Caucasians. And in the Africans, if you can see that there's a 37 base pair insertion at the fourth exon level, which leads to generation of a stop codon, and the gene becomes inactive, leading to an Rh negative phenotype. At times, Africans may also have the hybrid variants. Here, we can see that this lighter portions are the portions of the RHCE gene, which are replacing the RHD gene. So most of the RHD gene has been replaced by the RHCE gene, leading to a negative typing for the RHD. So these are the hybrid variants which are seen in case of Africans and some other ethnic populations. Now coming to the Rh antigens. Rh antigens are transmembrane proteins, and what is important is that they are non-glycosylated and non-phosphorylated with a molecular weight of 30 to 32 kilodaltons, and they are an integral part of the red cell membrane. They traverse the cell membrane 12 times, and they are covalently linked to fatty acids in the lipid bilayer. The RHD differs from the RHE by a good number of around 32 to 35 amino acids of the 417 amino acids, although the mature protein has 416 amino acids. And small loops are exposed on the surface after this, like the proteins traverse the membrane 12 times, and there are small loops which remain on the surface of the red RBCs. So because of these small loops, they provide the conformational requirement for the serologic differences between the Rh blood types, and whatever we are detecting by phenotype is based on these extracellular loops and the antigenic expression on these loops. This is the model of the Rh polypeptide showing that it is traversing the membrane 12 times, and these are the extracellular loops which are responsible for the antigenic expression. This is the transmembrane region of the loops. Both the amino and carboxy terminals are intracellular. The Rh antigens are well developed at birth, unlike the ABO antigens, and they are present only on the red blood cells. They are protein in nature with an active phospholipid component. And Rh proteins play a role in red cell membrane structural integrity and also transport of ammonia and carbon dioxide. They do not exist in a soluble form, and they are not excreted in the body fluids. So if we look at this diagram, we can see that this is the proposed membrane complex of the Rh along with the red cell membrane proteins. So there are tetramers of band 3 along with RHD, RHCE, and RHAG, which are lying in the membrane, and they are attached to the underlying cytoskeleton through protein 4.2 and enchirin. So this is the main reason why this blood group system is important in maintaining the structural integrity of the red cell. And in addition, band 3 may be present in another form in which the RHD and RHCE are attached to the underlying cytoskeleton through P55, adenosine, and protein 4.1. So this membrane topology is the main reason for the functional role of the Rh blood group system in the membrane, and this is also known as the Rh membrane complex containing all these various proteins. Now coming to the various antigens of this blood group system, as we all know, and whatever we read, this is the most common line that we read is that the D antigen is most immunogenic, and exposure to less than 0.1 ml of Rh positive RBCs can stimulate antibody production in an Rh negative person. So till date, more than 500 D alleles and more than 150 RHCE alleles have been documented, and they are maintained in various databases, and more than 60 antigens, as we have seen, have already been discovered. However, the 5 principal antigens are the cause of major Rh incompatibilities. And if we look at the order of immunogenicity, then of course D is the most immunogenic, followed by small c, capital E, capital C, and small e. Regarding the differences between the C and E antigens, this uppercase C and lowercase c differ by 4 amino acids. However, only the amino acid position 103 is important for C or uppercase or lowercase expression, because this is lying on the second extracellular loop, and same way the E amino acid substitution lies on the fourth extracellular loop, wherein capital E is denoted by proline and small e has alanine at position 226. So we can see in this diagram over here, we can see that this is the RHD, wherein we have the amino and carboxy terminals which are lying. Both are lying intracellularly. And the differences between the RHD and RHCE are shown on these open circles, which are lying extracellularly. There are 9 of these are extracellular. The rest of the differences are lying intracellularly or in the transmembranous region. And if we look at the RHCE, then this is this serine at position 103 on the second extracellular loop, which is responsible for the uppercase C expression, and proline is responsible for the lowercase c expression. Same way, alanine over here is responsible for lowercase e, and proline at 226 position is responsible for uppercase E expression. And these are the expressions of the rare antigens, that is a CW, this is also a single amino acid substitution, and CX. And this shared region present on the RHD and RHCE, where the C is in the capital C, this is responsible for the G antigen expression, which we'll be discussing later. And this 8 transmembrane loop has the VS antigen. These are rare antigens, and this zigzag denotes the covalent linkage to fatty acids in the lipid bilayer. This is a zigzag formation which denotes covalent linkage of these proteins to the lipid bilayer. So if we look at the number of D-antigenic sites which can be quantitated by flow cytometry, the maximum number of D-antigenic sites are on the rare D dash dash phenotype. This is also known as elevated D, where they are nearly 2 lakh, 1 lakh to 2 lakhs of the population in India is of R1R1. So R1R1 has around nearly 15,000 to 20,000 D-antigenic sites, whereas R2R2 besides that has a good number of D-antigenic sites. So the frequency of Rh antigens have been variably reported by different authors from India, and these are the few Western data. So if we look at this first study is from GMCH by Dr. Devjot Lamba et al. And the second one is from PGI, this one is from Delhi, and this fourth one is from Gujarat. This is the prevalence in whites and blacks. If we look at the prevalence of capital D antigen, D positive, then we can see that it is nearly 93 to 96% positive in the Indian population, whereas it is 85% in whites and 92% in blacks. Capital C is between 85 to 91% in Indians, 68% in whites, and just 27% in blacks. Small c is between 50 to 62% in Indians, 80% in whites, and 96% in blacks. So there is a large difference between the small c and capital C prevalence between the Indian population and the blacks. And also the capital C is different in the whites. Whereas the prevalences of capital E is more or less similar in all the populations between 20 to 30%, and small e is nearly 100%. But of course, we all know that if we get an anti-E, then it becomes a Herculean task to find an antigen negative unit compatible for that patient. So this antibody, if present at any time during cross matching, creates a big problem for the blood bank. Some unusual phenotypes, we can see that there are the CW antigen, although I may not be able to enlist all, but I've enlisted some important ones. It is a single amino acid change, and it is usually rare. And if at all an antibody is formed against this antigen, then it is easy to find antigen negative blood because it is a rare phenotype. Then we have the F antigen. It is expressed on the red cell when both the C and E in lowercase are on the same haplotype, and hence it is also known as a compound antigen. It is important because anti-F can cause hemolytic disease of fetus and newborn and transfusion reactions. Next is the G antigen, which is invariably present on the red cells possessing either the capital C or capital D. And antibodies against G appear superficially to be anti-D plus C, and they can be differentiated only by elaborate adsorption elution procedures, which is not routinely done because this anti-G usually it is not important to differentiate for transfusion purposes. However, if there is an anti-D plus C in a pregnant woman, then it is important to differentiate it from anti-G, because if the woman has only anti-G, then she is a candidate for Rh immunoglobulin prophylaxis. However, if she has both anti-G and anti-D, then probably she is not a candidate for Rh immunoglobulin prophylaxis. So it is important to differentiate D from G in obstetric patients. Now the question definitely comes to our mind that why is the Rh system so complex? And it is important to note that it is encoded by 2 genes with many identical regions with close proximity on the same chromosome. So this creates an opportunity for exchange events, and this leads to formation of multiple hybrid proteins, which are mainly gene conversions. And at times, new polymorphic proteins are created. So this leads to creation of a myriad of Rh antigens, As we can see in the school of fishes, if we see that they maybe seem to be visible just like to the naked eye, they seem to be similar, but otherwise there are a lot of differences which may not be seen on the naked eye. So why is the D antigen so immunogenic? As I had already said that D and CE differ from each other by 32 to 35 amino acids. So this is a big difference. And moreover, there are numerous epitopes of D antigen identified. Nearly 30 or more epitopes have been identified, which are highly conformational. And they have been numbered from D1 to D9 with various subdivisions. So whenever a D negative individual is exposed to D positive red cells, there is a robust immune response generated. So the D antigen has been rightly called as dominant, diverse, and difficult, both for the patient as well as for the blood bankers. Now, what causes variations in D expression? So we now come to the variants of the D antigen. The Rh antigen can be vary in the way in which it is expressed on the red cells because of mutations in the Rhd gene, and these variants are classified as quantitative or qualitative variants. Amongst the quantitative variants, we have the weak D, C in trans to D, the del, and the elevated D antigen. And the last one is the D epitopes on RHCE, which includes the DR and the Crawford, which are usually now considered under the altered CE variants. And amongst the qualitative variants, we have the partial D. So we'll be discussing one by one. If we come to the quantitative variants, there is reduced expression of D antigen in these variants. And now most of these variants are called weak D. Earlier, they were known as DU. The prevalence is 0.2 to 1% in whites. A similar prevalence has been reported in Indians also, but it is less than 1%. The red cells are not agglutinated by an IgM anti-D, but they require the use of an IgG anti-D along with an IgM and an antiglobulin. Reagent is also needed to take the test to the indirect antiglobulin phase. These weak D variants are attributed mostly to a point mutation in the Rhd gene, and at times they may not be due to gene alteration as in case of C in trans to D. The mutations cause the amino acid changes to be intracellular or in the transmembrane regions of the Rhd in case of weak D rather than on the outer surface of the red cells. So most of these mutations cause the amino acid changes to be in the transmembrane or intracellular region, not on the outer surface. These are single nucleotide polymorphisms and they affect the efficiency of the protein insertion. And finally, this leads to effect on the quantity of the protein in the membrane. So that is why it is a quantitative problem which occurs in case of weak D. And overall, the epitope expression is not affected in this case. Until date, over 145 different weak D mutations have already been identified, and these are uniquely different SNPs or single nucleotide polymorphisms. However, the most common of these are the weak D types 1, 2, and 3, which are unlikely to make anti-D as reported by most of the authors. But now recent reports, few authors have suggested that weak D types 1 and 2 can make anti-D. And so they have suggested that these weak D types may have altered epitopes. And now the term weak partial D has also been coined by some authors. So if we look at the mutations in weak D and partial D, over here we can see that in weak D, the mutations, most of these circles, if we can see, are lying transmembrane or intercellularly, whereas in case of partial D, they are lying on the outer surface or the extracellular portion, which leads to the epitope differences in the epitopes. This is the three-dimensional view of weak D and partial D. Now coming to C in trans to D. The allele carrying Rhd is in transposition to the allele carrying C, that is, it is in the opposite haplotype. So this will be the genotype of this C in trans to D. The capital C is in the opposite haplotype. And in this case, the Rh antigen is normal. However, the steric arrangement of C interferes with the expression of the D antigen. So because the D antigen is complete, so in these patients, D positive can be safely transfused. Now, another important variant is the DEL variant, which is very important for the Asians because it is a very weak form of D expression. And while other variants have a few thousands to even a good number of antigenic sites, the D antigenic sites in the DEL variant are even reported up to less than 30. So these are not detected definitely by routine serology methods, and they need to be demonstrated by adsorbing and eluting anti-D, or we need to molecular methods to differentiate the different DEL variants. And this RHD 1227A is the most important genetic marker for DEL, which leads to the RHD del type 1 phenotype. It is common in Asians. It has been reported in 10 to 30% of apparent D negative, and most of these populations are Japanese, Taiwan, and Korean populations. Although in India, the reported prevalence is less, but more studies need to be conducted, which will be seeing the prevalence in India also. And in Europeans, it is 0.027%. This DEL is primarily of concern for donor testing as it can stimulate anti-D if transfused, if a DEL blood is transfused to a D negative individual. If you look at certain practical aspects, recently authors have reported that DEL is associated with CE positive phenotype in many populations, and so they recommended RHCE phenotyping as a screening method for serologically D negative Asian donors in laboratories where it is not feasible to do molecular typing. And now it has been, although the transfusion recipients are not at risk of forming anti-D in case of DEL most of the times, but they say that some pregnant women with certain partial or hybrid DEL variants have shown have the potential to form anti-D. So again, DEL poses a challenge as a transfusion recipient. And of course, as a donor, we need to detect a DEL positive donor. If we look at some Indian studies on the DEL phenotype, this one is from Western India, wherein the authors studied 153 D negative donors by serology and molecular methods. However, they did not find any DEL positive by either of these methods. The second study, which was conducted in PGI, was on the frequency of DEL phenotype in Rh negative population of North Indian blood donors. Out of 200 D negative, the frequency of 1.5 was reported. However, they used only serology as the typing method. Now coming to the elevated D. In this, the individuals lack the RHCE protein and there is maximum amount of D antigenic site expression. So several phenotypes have again been reported in this depending upon whether the C antigen is present or it is absent. So if it is a D dash dash, then D antigen will be highly elevated. It could be DC minus or DCW minus, and these have an enhanced expression of D antigen, and no weak or variant CE antigens may be present. And this elevated D is just analogous to the partial D rearrangements, which we'll be seeing later on. Over here, there is replacement of the four parts of RHCE by RHD. And in addition to the normal RHD gene which is present. So the individual has enhanced expression of RHD because of the normal RHD gene and portions of CE also being replaced by D. So that is why the elevated D expression is seen in these individuals. And they can make anti-RH70 when immunized with the conventional CE antigens. Now coming to the most difficult variant, that is the partial D. In this, the red cells lack a portion of the D antigen and antibody is produced against the missing epitope. So the amino acid changes, as we have seen in the earlier figure, are located on the extracellular loop of the Rh protein if they are single amino acid substitutions. However, most of the times there is a missing portion of RHD which is replaced by CE in majority of the cases, leading to partial D variants, and this leads to generation of new antigens because of novel sequences. So if we can see in this diagram, we can see that this upper part shows the partial D types which are more prevalent in Caucasians. If we can see, this first one is D6 type, which is producing the BARC antigen. Then we have D5 type, which produces the DW antigen, and DFR type, which has the FPTT antigen. And over here, we can see that this darker portion represents the D gene portions, exons of the D, and these lighter portions are the exons of the CE, which are replacing the D gene. And at times there may be just a few amino acids, and so it may give rise to such stripe patterns of the exons, or a complete exon may be replaced. And in Africans, we have the new antigen generation in D3 type and D5 type. They have the DAK antigen and GO antigen. So all these antigens which are produced as a result of partial D phenotypes, they are also known as signature antigens for these partial D phenotypes, because whenever these partial D phenotypes arise because of these rearrangements of RHD and RHCE genes, these antigens, the novel sequences which are generated lead to the expression of these antigens, and hence they are known as antigens. Now, coming to the features of partial D, most of the time there is a gene conversion, and as we have seen that it may involve single or multiple exons, and it could be single amino acid change or short stretches of amino acids may be involved. So because of these multiple genetic mechanisms, they may either give a weak reaction or a strong reaction with anti-D reagents. It's not necessary that all partial D will react positive with anti-D reagents. Some may react, some may not react. And they may even type D negative if the specificity of the anti-sera which is being used for typing is against the missing epitope. Now, as I told earlier, that weak partial D variants are also recognized now. So although initially 7 categories were designated by Roman numerals from 1 to 7, category 1 is now obsolete and few categories have been further subdivided and new antigens have been formed due to loss of D epitopes. So hybrid variants which result from portion of RHD gene being replaced by portion of CE gene may consist of either an exon, a whole exon, or even several exons of RHCE. And now we have partial D typing kits, which are monoclonal anti-D reagent panels available in 6 reagent panel or 12 reagent panel typing kits to distinguish these partial D variants based on the pattern of reactivity with these monoclonal reagents. So because of these multiple genetic rearrangements, plethora of partial D antigens such as DBT, DFR, and DHAR have been recognized. And we can see over here that these are the low frequency antigens associated with the different partial D variants. And the reactivity of partial D variants with anti-D may be weaker than that of normal D positive cells in case of D6. It may be similar to normal D cells in case of D3, or it may be even elevated expression, and all this is because of the difference in the number of antigenic sites and the rearrangements that occur in these variants. And associated low frequency antigens have further subdivided these categories. So this is a few of the variants which have been enlisted over here, and we can see that most of the partial D variants, they are capable of producing anti-D when they are exposed to D positive. And these are the number of D antigenic sites. While there are a few hundreds in some of the variants, they are up to even more than the conventional D antigen in some of the variants. So that is why they can give varying reactions with different anti-D reagents used, and thus it may create a problem for the transfusion persons. And if we look at the weak D variants, these are all the weak D subtypes, few of the subtypes which have been listed over here. Some of them, just weak D type 15 has been shown to make anti-D. And now even there are few reports of weak D type 1 and 2 which have made anti-D. So most of the weak D types usually do not make anti-D, and they are usually seen in whites, all these weak D types. And the del types, as we can see over here, these are the last 3 other del types they are seen in Taiwanese and Japanese population. Over here, the antigenic sites are very few, less than 30. Now, partial D6 variant, which is the most common partial D variant and most important for all of us also, it has a low density of D and behaves like weak D, and many monoclonal anti-D may agglutinate weak D but not D6 cells. So for D typing of patients, it is important that anti-D reagents that do not react with D6 cells should be selected. And it is preferable that these individuals or these patients type as D6 negative so that they receive D negative blood. Because if they form an anti-D, then it can, particularly if they are women of childbearing age, it has the potential of causing severe hemolytic disease of fetus and newborn. And if gel cards are being used for typing of D in patients, then we should choose the gel card specific for patients which do not detect D6 variant. So D6 variants, we have D6 as further subtypes. If we can see that these hybrid are again different depending upon the number of CE exons that are replacing the D. In case of D6 type 1, just 2 exons 4 and 5 are replaced, whereas in case of D6 type 2, exon 4 to 6 are replaced. In D6 type 3, exon 3 to 6 are replaced, and D6 type 4, exon 3 to 5 are replaced. So that is why we can say that they have a different genetic makeup, and that is why, because of this reason, category D6 have RBCs that carry different amounts of the BARC antigen. All may not carry the BARC antigen. It depends upon the novel sequence that is generated, and D6 type 3 has been shown to carry the BARC antigen most commonly. Now coming to Indian studies on the D variants, in different studies have been conducted. In this study, which was conducted in Western India, the authors identified a major novel variant RHD allele in Indians, and they coined this as a weak partial D variant, because in this case, we saw that there was a 12 kilobase duplication event which included exon 3, and this led to a quantitative difference in the expression of the D proteins, the quantitative decrease in expression in addition to a duplication event. So that is why they considered this as a weak partial D variant, and this was found in 58% of the samples out of the 223 samples that they studied. So this variant was this they considered as a weak partial D variant in their study. In another study which has been conducted recently published in Transfusion Medicine, this is from SGPGI, wherein the authors have characterized the RHD variants in North Indian blood donors. And what they did was that they took all samples with discrepant D typings identified with at least 5 different monoclonal anti-D reagents. And these were subjected to molecular testing. And a total of 39 samples were tested, and they out of a total of 39 samples were discrepant, which included 19 RHD discrepant samples and 20 weak D samples. And in their study, they found that 13 samples had weak D and 8 samples had variants. And the overall prevalence of partial these D variants was 0.48%. Amongst them, the commonest were weak D type 1 and DFR1. So what they concluded was that few samples with weak reaction on serologic testing were found to be partial D variant, and those with the and it was vice versa was also the case. In another study by Kulkarni et al., the incidence of partial D was 0.15%, and these authors also found that 29% of these partial D variants were of the DFR category and 14.6% were of the D6 category. And they concluded that DFR was the most frequent partial D in the Indian population. As we can see that in the North Indian population also, DFR was reported as a common variant. So we need more studies to find out whether DFR is actually the common variant in the Indian population. And these studies need to be based on molecular typing, because even these authors used multiplex PCR to categorize the D variants. Now, there is a term called serological weak D. So if there is a reaction strength which is less than or equal to 2%, 2 plus with the routine typing reagent that is being used or routine typing method that is being used in the laboratory, or if there is a positive indirect antiglobulin test, it may give a variable reaction with different anti-sera, or there may be a discrepancy between the current and the historic D status of the individual, or there could be a demonstration of anti-D in a previously known RHD positive individuals. If any of these categories are satisfied, then it is known as a serological weak D. So Kulkarni et al. Have proposed a simple diagnostic strategy for RHD typing in discrepant cases in the Indian population, because in this study, the 60 discrepant samples were referred to their institute for confirmation of RHD status, and they were tested with a partial D typing kit containing 12 monoclonal anti-D reagents. And these authors, they found that 93% of these discrepant samples were characterized using this partial D typing kit. And amongst these variants characterized, again, 37% belong to DFR, 23 belong to DOL, and 12% belong to weak D. And the remaining 21% belong to other categories, including D5 and D6. And what they observed, another finding was that the 97% of the D variants were even capital C antigen positive. So they proposed that we should use 2 monoclonal anti-D reagents. First, a preliminary strategy was proposed that all the reagents which test negative by the LHM 70 by 45 clone which they had used, these variants tested negative with this clone, and then subsequently they were tested with the anti-C and they turned out to be positive. And the second clone that was used was amongst these 3 clones, LHM 76 by 59, 76 by 55, and ESD1. And these 3 clones gave a positive reaction with all the RHD variants that they had studied or characterized in their study population. So what they proposed was that we should use 2 anti-D reagents in discrepant samples, one which types all these variants as negative, and the second one which types all the variants as positive. And in addition, we can start C antigen typing whenever we get a discrepant case. And further characterization can be done using a complete partial D typing kit and molecular genotyping. If available, if not, we can refer the case to a higher center. So based on all this, certain points need to be pondered upon, that the validity of the assumption that a person with weak D cannot produce anti-D is now definitely challenged, because the precise location of the amino acid residues of the RHD protein within the membrane are not known. And these nucleotide substitutions encoding key amino acids have resulted in abnormal T polypeptide, and along with evidence that patients with weak D can produce allo-anti-D. So that is why weak D is not just a simple weak D, it can also produce allo-anti-D, and hence it is important that we use the term D variant rather than using weak D or partial D, and this should be based on genotyping and the potential to form anti-D. Now, a word about the Rh antibodies. Most Rh antibodies are IgG and can cross the placenta. They react at 37 degrees Celsius or after antiglobulin testing, and usually produced in response to exposure to foreign RBCs, transfusion, or pregnancy. We all know that they show dosage phenomena, they are enhanced with enzyme treatment, and they do not fix complement. And individuals of African or mixed ethnicity may possess the small e antigen with antibodies behaving as auto-anti-E. The Rh antibodies, although all four subclasses G1, G2, G3, and G4 can be present, the G1 and G3 are the commonest, and they are implicated in hemolytic disease of fetus and newborn and hemolytic transfusion reaction. An important characteristic is that they persist in circulation for years, and they may lead to an anamnestic response in individuals with low titers following exposure to the same antigen. So it is important that once an antibody is identified, then we should give antigen negative blood to that patient, even if it is currently demonstrable or not. Now, few words about Rh typing. High protein reagents were initially available, but now they are not used due to false positive results and various controls that needed to be put up along with high protein reagents. So now most of the labs are using low protein reagents, which could be either IgM monoclonal or a blend of IgM monoclonal and IgG polyclonal or monoclonal. And the suitable controls based on manufacturing instructions need to be put up. So if you look at Rh typing in donors, weekly testing is recommended in blood donors, which we all know, and transfusion of weekly positive blood to D negative recipients can lead to stimulation of anti-D formation. So FDA says that we should use two distinct potent anti-RHD reagents of two different manufacturers or two distinct RHD reagents of two different batches of the same manufacturer. If we don't have two manufacturers, we can use the same manufacturer with two different batches along with an indirect antiglobulin test, or if not, then a sensitive automated method should be used to type the D antigen in blood donors. And we need to use a blend of IgM and IgG polyclonal antibodies because the IgM antibodies are more sensitive to anti-D formation. And in blood donors. For Rh typing in patients, including pregnant women, they should be tested by an IgM anti-D reagent, or if it is a blend, then D should be detected in the immediate spin. And this reagent should give a negative reaction with the D6 red cells in order to avoid inadvertent D positive transfusion. So weekly testing, although it is not recommended for patients, but it is recommended in newborn infants of D negative mothers. So in order to determine the candidates for Rh immunoglobulin prophylaxis. Coming to the practical aspects, the anti-D, which is made by these D variant individuals, patients with D variant antigens, it may not be the same as the D negative individual because the amount of RHD gene that is being replaced by the CE gene affects the anti-D formation. And so the clinical significance may also be variable. But it is still important to note that some D variants may still type as D positive and thus have the potential to make anti-D when exposed to D positive cells. So this can only be avoided if we have a molecular typing. So as transfusion specialists, certain challenges are day-to-day, they come to us because of this D blood group system, Rh blood group system, because of complex epitopes and diverse alleles with varied expression. Antigen variants can be missed as in case of partial D. Expression level may hamper the detection, and moreover, there is variation in typing methods and type of reagents used across different laboratories. While one lab may use a tube method, another one may use a gel, or another one may use an automated platform. So because of these variations, the results may also be different across laboratories. The phase of testing, avidity, and specificity of anti-sera may also be different, which may affect the typing results. And other clinical, certain considerations which also need to be kept in mind are that if there is a positive DAT, it may cause a false positive weak D, and a block D phenomenon may be missed in a newborn born to an Rh negative mother with anti-D. If the newborn is Rh positive and all the antigenic sites are blocked by the anti-D, then we may falsely type the newborn as Rh negative if we don't suspect it based on the serological results of the mother and the baby. Another effect that is important for titration purposes is the Cepelini effect, wherein less D antigen is expressed when the C antigen is expressed in a double dose. So it is important that when we are doing anti-D titers, we need to choose red cells with the same Rh phenotype, because if we are using red cells with different zygosity for titers, then we can obtain different titers and it may affect the clinical management of the patient, particularly the antenatal patients who are undergoing the antenatal checkups. Briefly about Rh genotyping, although this is a separate topic, so I've just summarized in a single slide, that it can be used to type multi-transfused patients whenever there is a problem in serologic typing. RHD zygosity determination is important. That is, paternal RHD zygosity testing may be used to predict the fetal D status when the mother has anti-D. Fetal RHD typing, although invasive approaches were available, now a non-invasive method of testing cell-free fetal DNA present in maternal plasma or serum after 5 weeks of gestation can be employed to know the fetal D status and predict the risk for hemolytic disease of fetus and newborn, and giving the immunoprophylaxis to the mother. Confirmation of D status in discrepant cases, and providing antigen matched blood in a very important population, that is sickle cell disease patients which have a high rate of aluminization. The clinical considerations of Rh blood group system are separate topics by themselves. We have aluminization as a known with Rh blood group system in multi-transfused patients, and it is important once it is detected to provide the antigen matched blood. The Rh-mediated hemolytic transfusion reactions can also occur, which can lead to extravascular hemolysis. Hemolytic disease of fetus and newborn is a well-known entity with the Rh blood group system antigens. Warm autoimmune hemolytic anemia may at times and many times have specificity is directed to the commonly known as a specificity for the warm autoimmune hemolytic anemia patients. And Rh immunoglobulin prophylaxis issues in transfusion of Rh positive blood or platelets to Rh negative recipients in emergency. This is a subject of continuous debate about how much dose should be given and whether it is feasible to give if a person has been transfused a full unit of blood. So there are various views on this. So briefly about the Rh deficiency syndromes. These are the Rh null and Rh mod phenotype. These are usually rare, and individuals lack all the Rh antigens on the red cell surface in the Rh null phenotype, whereas in the mod phenotype, there is a partial suppression of the Rh gene expression caused by mutation in the RhAg. Clinical symptoms in the mod phenotype are usually less severe. The null is further divided into the regulator type and amorph type. While the regulator type has a mutation of the RhAg gene, leading to no D or CE protein expression on the red cells, the amorph type has a mutation of the CE gene and deletion of D gene. The RhAg is normal in this case. So these patients usually present with mild compensated hemolytic anemia, reticulocytosis, stomatocytosis, spherocytosis, and they may form anti-Rh29 if exposed to normal Rh cells through transfusion or pregnancy, which reacts with all cells except those that are Rh null. So now after all this, we need to know where to get information pertaining to different blood group systems. So there are various resources for blood group systems. If we can see, there are allele-oriented databases. The ISPT allele listings is available on the ISPT website. Red Cell, this working party on red cell immunogenetics and blood group terminology. This is the website. We have blood antigens, erythrogene, and human gene mutation databases, which are maintaining the various blood group system databases. And some of these databases have now been discontinued. But besides this, there are resources which are specific for the Rh blood group system. That is the RHCE allele listing at the New York Blood Center website and the Human Research Base Information, which is a very important site for the D antigen and its variants. And this site contains a directory of HTML files which are generated from an offline database, and the alleles are collated from publications and nucleotide sequences databases in a manual process. So they are enlisted under various headings like the ISPT allele nomenclature, mutation type, phenotypic group, ISPT group, haplotype, allele cluster, research-based name, year of publication, year of first description, and geography. And these are the guidelines for naming Rh alleles which have been proposed by the ISPT Working Party. So this conventional D sequence is assigned RHD star 01, and the common deletion in D negative is denoted as N followed by the subtype. And the inactivated 37 base pair insertion is denoted, which is seen in Africans, is denoted as 02 type. And then we have partial D variants, which are categorized according to the partial D category. Weak D variants are assigned with a W, and same with the CE alleles are assigned as a CE followed by the number of the allele. This is the representation of the ISPT allele nomenclature. We can see that 145 weak D types have been recognized, and these are the As they go on recognizing more and more variants, they are added to this list after a definitive publication occurs. This is a view of the research website wherein we can scroll to the different bars on this left pane, and then we can see the different variants. These are just a few of the variants. This is a one view of the website wherein we can see the designation, ISBT name, cluster, haplotype, mechanism, alterations, and first mention and the definitive publication of the same. So now, after listening to all this, we wonder whether the story ends here because Rh antibodies, because of altered Rh epitopes on transfused red cells, are even seen when the patient is Rh positive, as we have seen that this was a case series of 7 Brazilian patients, wherein they found anti-D in 2 patients, anti-capital C was found in 1 patient, small c in 1 patient, and anti-E was found in 3 patients. And all these patients, they carried the conventional D, C, and E antigens respectively. So what they found was that the units that were transfused to these patients who had the conventional antigens, these donors had the altered variants which led to these formation of the Rh antibodies. So not only the Rh negative individuals, but the Rh positive individuals or with the Rh positive phenotypes can also form antibodies. So that is a major concern for the blood bank. So there is a lot of scope of research in this subject. We can go for serologic and molecular characterization of T variants in different regions of the country to get a better understanding of what variants are prevalent in which particular ethnic group or population group. And then more research is needed on the Del variant which is reported to be common in Asian ethnicity. We need to formulate national guidelines for uniform testing strategy for donors and recipients, and follow-up of antenatal cases and scope of cell-free fetal DNA in the management of Rh negative pregnancy is another area of research which can be taken if the facilities permit. A few key takeaways from this presentation would be that serological typing cannot reliably predict a D variant as a partial or a weak D. Blood donors with a serological weak type should be managed as blood donors with a serological weak D type should be managed as RHD positive and issued special immunohematology cards. If a donor is a weak D phenotype positive, then they should be managed as RHD positive. Transfusion recipients and pregnant women or those in childbearing age should be managed as RHD negative and they should not be tested for the weak D. D negative neonates of RHD negative mothers should be tested for weak D to identify candidates for RHD prophylaxis, and RHD genotyping, if feasible, may be employed in discrepant cases. So this D dilemma, which all of us face, can be resolved by whenever we are handing out a report to anybody. It would be important if we can type such a line at the end that the Rh type is dependent on the reagents used, test performed, and the technical performance. Patients may be previously reported as Rh positive or Rh negative, and for transfusion service testing, the patient will be treated as Rh negative and a candidate for Rh immunoglobulin and will receive Rh negative blood. And as a blood donor, patient will be treated as Rh positive. So if such a line is typed, then it creates like the patients are well informed about why some labs are giving them Rh positive and some are reporting them as Rh negative. They may come and they may start litigation. So we can type such a line at the end of each report. So together we can fight COVID-19. Thank you for your patient listening.
Thank you so much, Dr. Paramjit Kaur ma'am, for explaining in detail one of the most complicated blood group system. So we have a couple of questions from many participants now. But before that, I request Dr. Joshi sir, if you want to have any comment or any addition you want to say, sir.
Yeah, actually, ever since I started my care, can you listen me? Can you hear me?
Yes, of course, we can hear you, sir.
So in early 70s, when we started working on RH and whenever we used to come to DU cases, there is unusual D. U stands for unusual D. And there was a dictum that as a donor, we have to consider as positive and as a recipient, we have to consider as D negative. Now, after a very long period, when all molecular things have come up and then secret behind the variants have come up, still we have the same dictum operating, that as a donor, we should consider this positive, and as a recipient, we should consider as negative. So there is very little progress from that angle, from practical angle. Of course, academically, we can understand better the RH system as well. Now, looking at the partial D, and weak D comes to be partial D, and we have to give D negative blood, as otherwise we have to give D negative. But what about normal D complement? Normal D reaction with anti-RH reagent, yet they have partial D, missing some of the epitope, and they are likely to receive RH positive with full complement D. They are likely to produce anti-D. And I had two cases. One case was referred from Bahrain, where sickle cell anemia case was ORH positive without any doubt with our reagents. And then still he has antibody, which was very strongly reacting, and it was turned out to be anti-D. So it was a partial D case as such. And there was one more case in Lucknow when I was working there. We had one A positive child, 9-year-old, and she had she was A positive normally, and then after and then she received 3 units of RH positive blood, and after 6 months she came back and she had anti-RH antibody. So, and we are not going to repeat the RH positive donor patients for partial D. So that is the limitation in our practice. That is what I wanted to tell.
Thank you, sir. Manisha ma'am, any comments from your side?
Yeah, for sure. I will just say that, thank you, Dr. Paramjit, for, explaining such a complex system in very little time. And I'm sure those participants who are, new to transfusion medicine, or they must be wondering that, they will come and have an idea that how important this blood group system is, and how, cautiously we must deal our serological labs and our work, and we cannot take anything lightly. Here I would say that, with the COVID-19, as she ended with the line that we must fight the COVID-19, it has come as a blessing in the diagnosis has come in a big way. And as sir was saying, we have made little progress because we always have, less equipped labs and less availability, still depending on serological tests, still dependent on the older methodologies. So I think we, the transfusion medicine people, should now take a lesson and bring in the PCR technology as a routine in our labs. As everyone now in India is knowing that crores of samples have been already tested with RT-PCR. So it's not a test which is now, some sort of a mystique principle fusion science, including the NAT. And here I will say that the reagents, whatever is available to you, as sir was saying, that still we do not have reagents which could detect, or we will still miss out some epitopes. So the clinical significance of this blood group should never be forgotten. And a very, very small example I will give you is that every time you open a reagent, and when you do quality control of these reagents, serologic, maybe just the serology, it should be taken very seriously. Which sometimes we think, oh, it doesn't matter, and from which batch the reagent is coming and what is happening. This happened with one of our, we just started getting, we just missed out on some negatives because the reagent quality control was not done when the reagent bottle was opened. And we found one of our regular dialysis patients who was B negative came for dialysis, and her blood group came to be positive. So there was a huge hue and cry, and we looked back, and last 2 days we had missed 3 or 4 negatives because there was some issue with the reagent. So very simple miss out, but a very, very important one. So I will just say that, have more quality control issues included. Don't forget to add molecular diagnosis. Important. Thank you.
Thank you, ma'am. We have a couple of questions for Dr. Kaur. Dr. Mohammad Anas Sheikh, Can you unmute yourself and ask your question?
Dr. Mohammed, you can unmute yourself now.
Yes.
Good evening, ma'am.
Good evening.
Ma'am, my question is with regards to autoantibodies. Ma'am, why is that most of the antibodies, autoantibodies are directed against Rh antigens?
This is basically it is anti-small e. E is actually E is a high prevalence antigen. So that is why it is said that it is auto anti-E, which is the most common Rh specificity against which these auto antibodies are directed. This
Is
auto
there any
anti-E.
specific molecular basis for that, ma'am? Why only anti-E?
I'm
the
not
prevalence?
aware of any molecular basis, but most of the time it is because of the high frequency of the E antigen.
Ma'am.
No, hello.
Right.
Hello.
Sir, good evening, sir.
Yeah. Actually, the small e specificity we can easily determine. But the problem is that it may not be only anti-small e, but at times you have antibody like anti-NL and anti-PDL. Means anti-PDL will not react with partially deleted antigen. That is D dash dash. So most
Sir.
of the warm antibody, particularly warm reacting autoantibodies, would not react with partial D. And so also NL means they will not react even with RH null. So
Sir.
because we do not have those rare red cell with us,
Yes, sir.
so we cannot determine the specificity. And at
Right,
times
sir.
we have R2 blood, we can determine the anti-small e specificity. Yeah.
Right, sir. Got it, sir. Thank you, sir.
Anybody else has any question? Dr. Jasmine Patel raised hand. Do you have any question? Dr. Jasmine Patel, in between she raised her hand. Disha, please.
Disha Parchure.
Disha, yes, please
Hello.
ask your question. Unmute yourself and ask your question.
Yes. Hello. Am I audible?
Yes, you are.
Yeah. Thank you, Dr. Paramjit. It was a nice, comprehensive talk. I would just like to add, I come from Dr. Kulkarni's lab from Mumbai. So the work that you showed from Dr. Kulkarni's lab, so the initial work, which was only based on serology from the 2013 paper, we found that most of the variants present were partial D, but it was only serology. So the recent research that we came out with in 2018, we found that serologically and molecularly we didn't find partial Ds to be present in a large number. So we also concluded on the same conclusion that serologically you won't be able to completely characterize a D variant, and molecular characterization is extremely important to distinguish whether a variant is a weak D or a partial D, and to also understand whether it has any reported anti-D. As you said, there are some weak Ds which are also which have also been reported to produce anti-D. So it is very important, as you mentioned in your talk, that molecular characterization be introduced in blood banking, especially for discrepant cases and
Yes,
especially in
but
case of
the
pregnant mothers.
infrastructure issues are always there, and it is not
Yes,
easy to
sure.
get a
Yes,
molecular
yes.
lab in every
Yes,
blood bank.
but as we came up with the research and we found that a single weak D mutation is responsible for almost 60% of the cases that we had received. So we had received both blood donors and referred cases